Danny, thanks for being here this morning and preparing to talk for us. And just wanted to introduce you for a sec. Danny's a UCSD neurosurgery fellow and has been involved with our program mainly through the educational events and some of the journal clubs, et cetera. And it's been great having you on board this year. And thanks for being here this morning to teach us on this whole sagittal plane. So.
Absolutely. Thank you for this opportunity. I'll do my best to try and impart some knowledge here. So as mentioned, my talk is on spinopelvic parameters and sagittal imbalance disorders. Nothing to disclose on my end. So in a simplistic view, this all derives down to the cone of economy, a kind of well understood idea that our head naturally wants to be above our pelvis, which naturally wants to be above our feet in the midline position. And deviation away from this cone of economy as we move away from this center point leads to increased pain and disability, primarily because of the increase in energy expenditure and the increased muscular and energy use that our bodies require to essentially keep our gaze horizontal while attempting to bring our head back above our pelvis. And this leads to a further increase in the spine, which can be seen from this figure coming from Dr. Rousseli, where gravity may remain constant as a force affecting the lumbar spine. But as we move away from this centered sort of position, the increasing stress of our muscular force acting upon the spine greatly increases as our body is initially able to compensate and use this extra kilocalories to be consumed to keep the head above the pelvis and such, but eventually does break down as the contact force, which he described as the gravity plus the muscular force is too burdensome for the individual suffering from this spinal deformity. The energy expenditure from this trunk flex posture has also been described and investigating using increases in oxygen consumption rate. And from this paper in 2007, by simply having healthy participants assume a trunk flex posture, then further and further over is seen in TF1 as well as TF2. There is a notable increase in the oxygen consumption rate that these individuals must utilize even for this short 5 to 10 minute flexion posturing that they took on for this study. And when you think about that for patients who are forced to be in these sorts of positions somewhat permanently, it becomes quite profound. But what kind of data do we have to demonstrate how profound or debilitating these conditions can be? Is it not just a aesthetic problem and inability to wear certain clothes? Well, data coming out of the International Spine Study Group has demonstrated using a large cohort of patients and using SF36 to identify that symptomatic adult spinal deformity is on par in terms of the physical component issues with cancer, with heart disease, with lung disease, and is in fact more debilitating than diabetes, hypertension, depression, and back pain, and of course significantly lower than the healthy population of 55 versus the 40.9, which is equivalent to cancer within this group. And so we now can understand that this certainly is a serious problem that many patients suffer from and come to their surgeons for help. So in order to speak about spinopelvic parameters, we need to go over the kind of fundamental language that everyone uses. And I won't belabor this too much because I'm certain that now in 2022, this is much more common and understood than it was even 5 to 10 years ago. But briefly, we need to be able to understand our lumbar lordosis, to a lesser degree thoracic kyphosis, our pelvic incidence, which is a measurement of a line that is orthogonal to the center of the sacral end plate going down to the femoral head. Then the pelvic tilt, which is a line taken from the center of the sacral end plate down to the femoral head based off of the vertical line coming off of the femoral head. And then, of course, the sagittal vertebral axis, which is a C7 plumb line dropped from the C7 centroid and then measured as a distance from the posterior superior end plate of S1. Briefly, pelvic tilt, an adjustable parameter, able to be antero-retroflexed and adjusted, and is frequently one of the first compensatory mechanisms that patients will assume if they develop any sort of symptomatic scoliosis, and is generally less than 20 degrees. Pelvic incidence, contrarily, is a morphologic parameter. It is essentially fixed, although some data suggests it's not quite as rigorously fixed as we like to dogmatically say it is. But in essence, we treat it as a single number which does not really vary from the patient throughout their life, simply because it is fixed to the pelvis and the femoral head's anatomy. There is, of course, a relationship between these two angles, and once derived, we understand that pelvic incidence is equal to pelvic tilt plus sacral slope. I left off sacral slope from the initial kind of description of the terms that we'll be using, because sacral slope is essentially directly related to the previous two variables. And so if we understand the pelvic incidence and we understand the pelvic tilt, then we can very easily derive the sacral slope, and such we can use a simpler sort of use of language to describe the same sort of ideas without bogging down too many numbers and variables, making things simpler for everyone. Of course, there's thoracic kyphosis, normally 20 to 50 degrees, directly impacted by lumbar and pelvic anatomy. Lumbar lordosis with an average of 60 degrees, very wide range of acceptable values depending on the patient's morphology, age, pelvic incidence. But it's important to note, and it'll come up later, that approximately 66% of lumbar lordosis comes from the lower end of the lumbar spine, with at L4 and S1, with almost 50% of that occurring at L5 and S1. Now, when discussing lumbar lordosis, we need to understand that data coming out of various groups, including the International Spine Scoliosis Society, shows that the loss of lumbar lordosis is especially poorly tolerated, where areas of kyphosis within a large cohort of patients generally do increase the overall ODI, but it is worst, or the least amount of tolerance occurs within the lumbar spine, where once kyphosis progresses, it leads to worsened SRS as well as ODI scores, suggesting that the body truly wants to maintain a harmonious curve and includes lumbar lordosis rather than lumbar kyphosis. And so once again, these parameters relate directly to each other, where pelvic incidence can help identify the amount of lumbar lordosis that a patient should need. And the most well-known derived equation is that lumbar lordosis should be equal to the pelvic incidence plus or minus 9 or so. But we need to think about what this means for different patients and how that will affect the type of surgery that would maximally benefit them without the fear of complication. And so there are several descriptions of classifying patients and their natural sort of harmonious shape. There are patients, according to the Rousseli classification, with a low PI versus those with a high PI. And the effects of this is more than just nomenclature so that we can describe these in the literature. It directly affects where the surgery should be done and how it should be done. For example, with a type 1 curve, they have lower sacral slope. Assuming they have a normal PT and they have a low PI, we know that the lumbar apex would actually be quite low, simply because the greatest proportion of the lumbar lordosis will occur from the lumbosacral junction. And so performing, say, an L1 PSO on this patient may not be the best option. Compare that to a patient with a type 4, where they have a very high sacral slope, a very high PI relative to the majority of the population. And we can see that the apex of their curve, not only is it larger, but it's higher up. So it's more at L1, L2, L3, and such. A PSO might actually be more beneficial because it is harmonious with the type of shape that their body may have had when they didn't have degenerative scoliosis or whatever their pathology was back when they were 22, 23, and generally healthy without any spinal issues. And by restoring them to what their body naturally wanted to be, rather than forcing them into a separate type of category by manipulating lumbar lordosis incongruently with what their PI is, allows us to really kind of understand why we're doing what we're doing and how to prevent iatrogenic injury and future surgeries. By simplifying this diagram down even further, simply to the lines with a triangle representing the pelvis, we can really kind of understand that there are a vast variety of appropriate curves that we can see within the normal population, and we shouldn't be aiming towards a cookie cutter sort of spine. and that we need to incorporate the patient's natural pelvic incidence as we decide how much of a flat back we can tolerate, because ultimately there is such a thing as a, quote, harmonious flat back, which would be a type 2 Russley classification, where there is a small arch, a small amount of lumbar lordosis, but an appropriately small amount of thoracic kyphosis at the same time, secondary to their low pelvic incidence, versus attempting to create robust curves that can be seen in type 4. But now we also need to consider the person who may be watching who says, you know, I'm not a deformity surgeon. I'm not doing these large T10 to pelvises, occiput to the pelvis, quad rods. I'm a community neurosurgeon, orthopedic surgeon. I like to do simple 1 to 2 level fusions. How relevant are these parameters to me? And I think we understand now that they are extremely relevant. This is a study where they were able to identify the influence of pelvic incidence and lumbar lordosis mismatch, leading to symptomatic adjacent level disease requiring surgery following a single level TLIF. They had 159 patients, and they demonstrated with their data set that a 1% increase in mismatch led to a 1.4 odds ratio increase in a surgically necessary revision for adjacent level disease, and that a PI-LL mismatch of greater than 11 degrees has a positive predictive value of 75% of needing revision surgery. It's like, I don't recall who said it initially, but I know that some of my mentors have said, only the first spinal surgery or fusion is elective. And once you lay hands on the patient and you affect their spine, you've purchased them, and you've purchased every single revision surgery that will need to come down. Moving on to SVA, or sagittal vertebral axis, generally should be less than 5 degrees. Once again, C7 centroid down to this posterior superior S1 end plate. Similarly to PI-LL mismatch, we can see that an increase in sagittal imbalance leads to worsened SF12 as well as ODI scores. And while this is all well and good, it is natural for us to want to have those perfect x-rays to pull the spine back, make everything beautiful and harmonious, but this is lacking one important factor, the fourth dimension, forgive the pun, by taking a large cohort of patients, 773, and reviewing the way that age affects what we want our heads and spines to be doing. So by taking these patients and extrapolating age-specific ODI values and the physical component of SF36, they're able to identify that the kind of dogmatic Schwab classification values that we learn begin to break down as the patients age, and they continue to have appropriate ODIs. At age 55, their pelvic tilt is now an average of 22 and continues to increase to 30. Similarly, the PI-LL mismatch increases once over 74 to 13. SVA, no longer less than 4 degrees after the age of 65. And so when evaluating the patients, you know, those of older age who potentially could benefit the most from this disability, it's important to think about the importance of overcorrection and getting them to an age-appropriate value. So this group, the International Spine Study Group, then derived these relatively understandable formulas, which will allow one to create the age-adjusted spinopelvic parameters. Ultimately, life and aging is a kyphosing event, and so we need to incorporate the changes that will naturally occur as patients continue to age. There's loss of lordosis, pelvic retroflexion, and eventually becomes decompensated, but no longer needs to look like that 18 to 22-year-old spine. And we can do less surgery and still get an equally good result without putting the risk of oversized implants, additional osteotomies, etc. And so here, this is kind of validating what I'm saying, that overcorrection versus undercorrection is a significant variable to think about, and that patients who are undercorrected based off their age-adjusted SVAs, of course, do demonstrate worse clinical outcomes. The goals of the surgery may not have been met. However, importantly, there were minimal to no improvements following those who were overcorrected beyond the derived age-adjusted values based off of their ODI and their physical component scores on the SF12 and, of course, in the SRS. This was most significant for SVA rather than PILL and PT. And so as one ages, we need to think about, or as one develops further scoliosis and symptomatic deformity, think about what types of compensations occur and where do they occur. One of the first ones is a reduction of thoracic kyphosis. However, this is somewhat limited, especially when we move into an older population where they no longer have such a flexible spine as you may see in the pediatric population or the young adult population. And such, we have to look at additional compensatory effects. Some include changes down at the segmental level, where there is a hyperextension in one or even several segments, leading to a hyperextended disc with anterolisthesis at the same level, as can be seen here, this quote lean back sign, where the posterior end of the end plate is now essentially attempting to touch the superior end plate posteriorly of the adjacent level. Pelvic retroversion, a well understood phenomena, very easy to do, and one of the first ones to be exhausted as well, simply because this increase of pelvic tilt leads to further rotation around the head of the femoral heads, and can allow to maintain that cone of economy for a while, but there's only so much that can be done, and it does lead to additional activation of hip extensor muscles, including gluteal muscles and such. And so once exhausted, not only are the patients already utilizing a higher amount of energy simply to keep themselves upright, they now need to move on to even larger muscle sets, which are less efficient in compensating for instability or scoliosis and deformity. So for example, they would now move on to hip flexion. And I invite you to think back to your days in high school gym and attempting to do wall sits. I mean, there's a reason why we do wall sits for 30 seconds to a minute, maybe more if you're, athletically inclined, but my quads would be burning the entire time. And that is the type of expenditure that some of these patients who truly are decompensated need to expend. And that's why they become so reliant on assistive devices, on family members and caregivers, getting them through the day, simply because the amount of energy and difficulty it can be to get to where you need to be in terms of your balance. Beyond hip flexion, we go to even more inefficient areas where we're now looking at knee flexion and ankle extension. You see these patients in clinic coming in and they're a zigzag, their butt's sticking out, their knees are sticking out, simply because they're doing their best to keep their head above their pelvis and above their feet so that they're able to look people in the eye and swallow appropriately, and all these things that we generally take for granted. And so by putting it all together, we can look at this model where they have this, for whatever reason, kyphosis over. They have this downward gaze, stooped posture, and then they attempt to compensate. They're extending their hips, they're rotating their pelvis, they're flexing their knees, and finally, they are able to restore their gaze. Such an example can be seen here in the UCSD neurosurgery clinic. But, kind of joking aside, these young, healthy people performing the limbo presumably have a normal SVA. Presumably they are in line. And just like wall sits, I invite you to think about the last time you did the limbo and how difficult it can be. And note how these individuals are looking straight up into the sky. They are not making eye contact. They're not doing anything they need to do versus the patients who may need to adopt a gradient of this type of posture in order to advance with their activities of daily living. And it really is profound that we're in an era of the study of spine surgery and the types of surgeries that we do so that we can understand why we're doing it and how we can prevent the iatrogenic flat backs that we may see nowadays, that we prevent adjacent level disease and segment disease in these patients who, forgive the pun, are essentially in limbo. They are trying to live their life, but they are burdened by this terrible disease, which prevents them from doing even the simplest things without an enormous toll on their body in terms of pain as well as energy expenditure. And that's why I'm just so profoundly grateful that we have this wealth of literature that continues to advance every day. And so with that, I appreciate your time. I understand it's later in the day and there may be cases, but I'm open to comments and questions, and I'm happy to answer.
That was a great overview, Danny. Thank you so much. My fellows know I always harp on this, which is this whole concept of age appropriate alignment. I'm not sure I personally believe it, because it's in direct contradiction to everything we teach. I also just clinically, I don't think we totally understand why one person with an SVA of 7 is miserable and the other person with an SVA of 7 is fine. So I think it has to be more than just the parameter. And then, to go back to the basic flaw of using something like an ODI to base that massive conclusion off of. And so you're using a disability questionnaire that was not made for deformity, and you're translating it into a statement that could lead to a lot of adults being flat back, or have a positive. You end up with a sort of negative alignment, not negative alignment, but poor alignment. So I actually kind of believe in restoring patients back to their Roussel type more than I believe in the whole age adjusted thing. I do think overcorrection is worse than undercorrection. And so I totally echo what you say there, because certainly when we overcorrect patients, we really engage their compensatory mechanisms, which typically leads to bad things, So I guess if you have to cheat one way or the other, I would probably lean towards an undercorrected state rather than an overcorrected. But that's my only 2 cents I'll throw at you with regards to the age alignment. I would approach it with some skepticism, and keep your eyes open with your patients as you talk with them to see how they're actually doing and how they're feeling, because you may be surprised that it's the age alignment thing may not always add up.
Understood. Thank you.
Any other thoughts from the group that's still on?
No, I concur, Greg.
Cool. Well, thanks, Danny. That was awesome. I appreciate you being here and sharing with us. And good luck on the rest of your year.
All right. Take care.
And
have a good day now.
Yeah, absolutely. Okay, guys. Have a great day.
Less with other factors than age, with maybe they have a 5-degree knee contracture on either side, or something that's fairly subtle but has sort of implications with how their spine is balanced that you need to factor in, and less the age, even though we sort of derive that from an outcome measure. So look at the whole picture, and you have to go through the fine-tooth comb to really understand the ripple effect of all of those little issues in the extremities and the rest of the spine that result in some compensatory reciprocal change.